Good morning. Good morning, everybody.
Morning, sir.
Good morning, Aishwara.
Evening, sir. How are you,
Good
Dr.
morning,
Hudson?
How are you doing?
I'm great. How are you?
Everything fine. Thanks. Good morning, Rodrigo.
Good morning, Dr. Nakamura. How are you?
We are fine. Thanks. Was in Brasilia yesterday, seeing patients, and things are getting back to normal,
Great.
quite faster than I thought. And I guess the foundation, things are getting back to
Things are
normal
getting,
too.
yes, getting better.
Still, we have to be aware of the COVID things and use masks and protect ourselves. This is so important. Good morning, Natarajan. How are you doing? I like your shirt. It's a Brazilian shirt.
Sir, you're muted. Natarajan, sir, you're muted.
I have a Brazil t-shirt. I was telling
Yeah.
I have a Brazil t-shirt.
I like the
No,
T-shirt.
this is a new t-shirt.
The official one. That's the official
Hey,
one.
I have a selfie with my 103-year-old girlfriend. I've sent it.
Oh yeah,
I sent it in the group.
that's great. How do you like soccer?
I like very much. Only problem is I don't have time to see, and most of the time it's in the midnight when it's being played. So we can't. I sleep off because I was traveling.
Yeah, I know.
Actually, I
And
lost count for several years because of the my travel and my schedule. I think
yeah,
like after a long time when you reminded me, whenever I'm in the plane, sometimes I see the recorded one or in the airport waiting.
yeah. People are getting back to normal now. The games are starting. I have this local team here, uh, who is called Goiás, the team of my state.
Oh,
But I don't actually follow. I'm listening here and there, and I
okay.
used to be more prone to watch the soccer games, but not those days anymore. So let
So
me.
so we have a South Indian like a soup. It is. I'm going to show you. You have to see what it is before the others come.
Yeah, let me. Good morning, Sheila John. How are you doing? And let me just get hold of
It's connecting.
Jessica again because she's having some
Jaideep, good
trouble.
afternoon.
Good afternoon, sir. Good morning, Dr.
Hudson,
Hudson.
Hudson, you have to
Yeah,
congratulate Jaideep because we have got a publication in Indian Journal of Ophthalmology, one of the first reports in the world of central. You tell Jaideep.
Uh, sir, we reported a case of a central retinal vein occlusion in a young girl, 17-year-old girl, post-COVID infection.
it's a
So,
central retinal vein occlusion.
yeah, central retinal vein occlusion in a 17-year-old
Oh
girl.
yeah. I think in the last meeting you reported that you told us, Natarajan, In
Correct.
the,
In the
yeah,
in the correct.
you said you have a case of central retinal artery
Yeah.
occlusion as well,
Yeah,
no?
that is a second patient. So that
Yeah.
Aishwarya
Yeah, we have
and Aishwarya and
a
Dr.
combined
Gopal.
occlusion.
Yeah, combined occlusion, the same patient or
Yeah.
two patients?
No,
different
another patient.
Another
Another
patient.
patient with
another patient.
So a lot
Another
of reports are coming now. And then there is a BBC interview 2 days back saying that 30% of the post-COVID patients, when they go back home, they are developing deep vein thrombosis.
Okay, okay. Yeah, that's fine to
Yeah.
report, I have heard some, but I did not have, we did not have any case.
Hudson, cheers.
Yeah, cheers. I have
So
a
now
tea.
Aishwarya will describe this. Aishwarya or Pooja will describe. Pooja,
Yes,
Good
sir.
morning.
tell us, what is this?
Thank you very much. I think Jessica is already in. Hi, Jessica. How are you?
Hi, I'm fine, and you?
So did you like the today's creative work done by Aishwarya?
Yeah, it was very good. Yeah. Very good design.
So the Jessica
I-
design, sorry, she put Jessica and she didn't put her own picture.
Hi,
Hello,
Kanish.
doctor. I'm Dr. Gopal. I'm from Kochi.
You
Hi,
are in the
Dr.
war?
Gopal.
Hello.
Gopal is a
Doutor
veterinary
Hudson.
surgeon and
Sim.
the chief of
Precisa habilitar
of
para eu
ophthalmology.
poder compartilhar a tela aqui.
Sim. Jessica wants for me to make her co-host so that she can share.
Thank you very much for this joint venture, sir. Really
no,
great.
Gopal,
Appreciate it.
Hudson, Dr. Gopal is my friend and chief and professor of ophthalmology in Cochin. That's where
Cochin.
Aishwarya studied her exams and passed her exam. And I think
Oh,
she was good.
congratulations.
Gopal Pillai was the chief examiner. And
See you,
me
sir.
and Gopal Pillai are establishing a thing called a clinical trial network in India. And we are planning to establish drcr.net in India.
Yeah, DSR.net in India.
Yeah.
Yeah, great. Great.
Similar. Maybe we'll do one day better.
Is there is that very complicated to get into the DSR.net, or it's something
No.
that
We are creating our own. We just started. We got a grant. I don't know how much it is in dollars, but it's an Indian government grant. 6 institutes are involved, and Dr. Gopal is the chief. He's my boss.
Yeah, this is awesome.
Yes, Gopal, how many cases today?
Yeah, my
congratulations.
last case going to just start. So
Okay.
it's okay. I'll be free in about half an hour.
Okay. So anyhow, thanks
All right.
for sending Aishwarya to us.
See you.
Ella
Let's just continue. I'll join you later, sir.
Okay.
I'll join you
You
later.
are in the war, I guess, no?
Yeah, he's operating one more case. Yes. Yeah. Yes. Thank you, Gopal. Okay. So Hudson, we can start. I think Jessica.
Yeah,
is
let me.
Aishwarya, you will introduce Jessica to our friends.
Yes, sir.
Yeah.
Okay.
Hi. Hello, everyone. I would like to introduce Dr. Jessica Fassbender. She's a surgical retina fellow. She's working in Brazil, in Guyana, and it's I don't know. I'm not sure how to pronounce the name of your hospital, sir. It's in Portuguese, so please do help me out with that.
Hudson can help. Hudson, she wants to tell your.
Yeah. Just a moment. I'm trying to connect my. These phones give me a better.
Okay.
Better listening.
Dr.
Just
Jessica
a
will be
second.
talking to us
Jessica, you
about.
ready?
Okay.
Yeah, so she'll be talking to us about OCT, and she will be talking to us in Portuguese, and Sir will be translating for the benefit of the non-Portuguese speaking population in this meeting. Okay, thank you so much.
Yeah.
Hudson, she wants you
So
to.
Jessica, everything is all right? Well, just give me
Right.
30 seconds to start. Just a second.
Posso iniciar então, doutor?
No, só um minutinho, just a minute. I'm trying to connect this. This is very good actually, but today decided not to work. Can you listen to me?
Sim.
Okay, I'll just leave it. Okay, Jessica, you could go ahead. So Jessica is going to start talking about OCT, optical coherence tomography. As we pointed out in previous lectures, and we all know, at least me, Natarajan, and somebody else know that we started so many years ago doing, pathology. The pathology is not so well used today, but today we have OCT. That is a very interesting tool, very important tool, and nobody can do a retina without OCT nowadays. So you gotta get used to OCT and diagnosing and seeing patients, and especially macular patients. It's important for pre and post-operative comparisons and classifications and decisions and everything. So there's a whole history behind this, and so that's why we have to know much. And Jessica is going to start her talk now. Okay, Jessica, go ahead, please.
Hassan,
Yeah.
We were the Aditya Jyoth was the first to introduce OCT in India in 2001.
2001, yeah.
Yeah.
This is history.
20 years now.
Yeah, this is great. This is great. And you know how it was complicated before, and today things are much better. Okay, so Jessica is gonna speak, and it's written in English, but most of what she speaks I will be translating. And she's got a quite good English, but she's not been practicing as of yet. But so go on, Jessica.
Então, vou falar hoje sobre o OCT. A principal tecnologia utilizada hoje na prática clínica é o spectral domain.
The main technology today in the clinical practice is a spectral domain OCT, SD-OCT.
Que ele nos proporciona imagens em 2 e 3 dimensões, numa resolução tão boa que chega a ser comparado a uma biópsia em vivo.
So it provides 2 and 3 dimensional images with near cell resolution that is so good that it's close to in vivo biopsy.
A base do OCT é através de comprimentos de onda próximo ao infravermelho, que vai iluminar a retina, e através da reflectividade dessa luz, através do espectrômetro e transformação de Fourier, vai ser proporcionada a imagem das camadas da retina.
So it uses the long wavelength, near, the invisible wavelength 840, to illuminate the retina and assess the light reflected from retinal tissue interfaces using spectrometer and transformation type Fourier.
O spectral domain, ao contrário das tecnologias mais antigas, que era o time domain, eles conseguem ter uma taxa de screening muito mais rápida da retina.
You can actually have a faster screening scan with a spectral domain as opposed to time domain that was used in the past.
Uma outra tecnologia hoje muito utilizada é o swept source, que além de ter uma velocidade muito mais rápida dos scans, também consegue uma profundidade maior da onda de luz, podendo ter imagens mais nítidas da coroide.
So we still have more accurate and focused images with swept source. It uses the faster scanning speeds of 100,000 to 400,000 scans per second, and the longer wavelength that provides better visualization of structures and how beneath the retinal pigment epithelium.
Aqui uma imagem de um OCT normal, onde a gente visualiza, então, o vítreo e as camadas que eu vou comentar a seguir.
Okay, a imagem não aparece. Ah, okay, yeah, that's the image. So you actually see all layers, and this is very good. Then you have comparison at the foveal area and all the structures, and it's important to see the RPE as well.
Algumas perguntas que a gente precisa responder para a avaliação inicial do OCT. A primeira é se temos uma espessura macular normal e se o contorno foveal é normal também.
The first question is, do we have the normal retinal structure and the foveal depression and the foveal contour, is that okay?
Se existe algum espessamento ou afinamento na retina,
Any thinning or thickening of the retina?
se a zona elipsoide está intacta,
Is the EZ zone intact?
se existe alguma outra afinamento retiniano,
So we gotta look at the outer retinal layers too and see whether it's thin or not.
e se a coroide está espessada ou não.
And also thinking of pachychoroid diseases and what about the choroid? Is it thickened or not?
Então, através do B-scan, essa primeira imagem, a gente consegue ver a espessura retiniana. Alguns tomógrafos utilizam entre a membrana limitante interna e o EPR, e outros entre a limitante interna e a membrana de Bruch para medir essa espessura.
So some OCTs, they vary, but some measure from the ILM towards the RPE, and others go a little further towards the choroid, the Bruch's membrane.
Outra importante informação que o OCT nos dá é os mapas tridimensionais. O primeiro é a membrana limitante interna, o segundo, o EPR, e o terceiro, o mapa de espessura retiniana.
So you got three maps below. You see from the surface to the internal limiting membrane and the middle, the retinal pigment epithelium, and the retinal thickness map in the third drawing there. And also you see up above the B-scan cuts.
Então, a primeira estrutura que a gente vê no OCT é a membrana limitante interna, que ela é uma estrutura hiperreflectiva. Alguns pacientes pode ser visto uma hialoide aqui hiperreflectiva também no vítreo.
So you actually see the first structure up above you see is the internal limiting membrane. You can actually see as well the hyalod attached or not, depending on if you go further or a little behind, and to see the hyalod and even other structures in the vitreous might be seen at this time.
A camada de fibras nervosas e as plexiformes interna e externa, elas são hiperreflectivas no OCT.
The retinal nerve fiber layer and the plexiform layers, they are hyperreflective.
Ao contrário, a camada de células ganglionares e as nucleares interna e externa aparecem como hiporreflectivas.
As you can well see in the image on the right, the ganglion cell layer and the nuclear layers are relatively hyporeflective, and you just take a look and you can see the difference.
Aqui na retina externa, a gente pode separar algumas camadas que são importantes. A membrana limitante externa, a zona elipsoide e aqui a zona de interdigitação e EPR.
And so you can actually see here in the posterior part, you can see the junction. Repeat, please, Jessica, one by one. Repita uma por uma.
Membrana limitante externa.
External limiting membrane.
Aqui a zona elipsoide.
Ellipsoid zone.
E a zona de interdigitação junto com o EPR.
The RPE interdigitating zone.
Então, para analisar alguns OCTs, para a gente ver o que ele pode nos auxiliar nos diagnósticos, aqui um OCT normal para a gente comparar todas as camadas preservadas, a depressão foveal preservada.
So this is a normal OCT, just for comparison, and you have the normal depression of the foveal area.
Aqui primeira alteração, uma membrana epiretiniana, onde a gente vê uma linha hiperreflectiva, aqui deformando a depressão foveal e presença de cistos com edema intraretiniano.
A imagem ainda não veio, the image didn't come yet, and she's talking about the epiretinal tissue, epiretinal membrane. Cadê a imagem, Jessica? Where is the
Apareceu
image?
não?
Ah, okay, yeah, now, okay. So you actually see the line up above there, actually causing some traction, but you have this line individualized. That's the epiretinal membrane on the surface of the retina. And you see the normal foveal contour is lost, and the retina is probably thickened.
A próxima imagem é uma síndrome de tração vitreomacular, onde a gente tem um aumento da espessura retiniana com cistos e a atração do vítreo sobre a retina.
Next image, you see the vitreomacular traction syndrome. You see the cysts as well inside the neurosensorial retina there. And you see attachments here from the vitreous and increased retinal thickness in the red areas.
E o mapa de elevação da retina, a gente nota a área de edema nessa área vermelha.
Edema, cysts and subretinal fluid, intraretinal cysts due to the vitreomacular traction and epiretinal membrane.
Aqui um caso de tração também, com inversão do contorno foveal e a presença de uma grande cavitação na região da fóvea.
As you see here, you have at the foveal area. I think the next image, Jessica, a próxima imagem.
Para mim está aparecendo, acho que está só um delay.
Yeah, okay. Yeah, it's just a delay. Vitreomacular traction with an inverted foveal contour and underlying cavitation. This is very interesting to see, and I have some cases where we did vitrectomy, and we have to be extra careful with these adhesions. Otherwise, during the surgery, because in this case, it's necessary to do surgery because the traction is so much, you might actually cause a break there and cause a hole, full thickness. So you've got to be very, very, very careful by doing the surgery.
Aqui um caso de buraco macular de espessura total, onde a gente tem também presença de cistos intraretinianos com edema, e é possível medir o tamanho do buraco fazendo uma linha paralela ao EPR na área de menor distância entre o buraco, entre as camadas.
We actually can measure the size of the hole at the smallest distance from that where she's pointing to the other side to actually measure the macular hole. So it's a full thickness macular hole. And if we go back to one slide, we see the traction before that might have caused this as well. So this is a full thickness macular hole.
Aqui uma imagem de um afinamento importante da retina, onde a gente nota que a zona elipsoide hiperreflectiva ela só está mantida subfoveal. As demais localizações estão perdidas na retina externa.
As you see, you have the damage of a central ellipsoid zone. So if you take a good look at the ellipsoid zone where the hole is, you can actually see where the damage is as well. And this is a severe thinning of the outer retinal with sparing of the central EZ. And this patient has retinitis pigmentosa.
Edema macular diabético com a perda do contorno da fóvea e a presença de grandes cistos intraretinianos.
Next image is a diabetic macular edema with very large retinal cysts as you can see.
E também aqui a gente consegue ver uma perda da parte externa, zona elipsoide aqui, parte externa da retina.
You see the ellipsoid zone there also with problems. So it's very important that you take a very good look at the OCT and actually analyze this ellipsoid zone, because some tractions and some cysts, some long-standing cysts, some chronic changes in the retina, especially the neurosensory retina, might pose the problems at that area. So that has to see also with the outcome of the patient and the chronicity of the processes.
Aqui um exemplo de membrana neovascular coroidiana, num paciente com DMRI exudativa. O descolamento do epitélio pigmentar aqui, ele é fibrovascular, porque a refletividade interna do DEP, ele é heterogêneo com áreas de hiperreflectividade.
Okay, and the image did not get yet, but the next case she's going to be showing is, yeah, that's the one, the neovascular choroidal membrane. And you see here, the changes in the sensorial retina, as well as the lining of the retinal pigment epithelium, which is actually, as you see here, is detached, and the patient with choroidal neovascular membrane and exudative age-related macular degeneration. So this is more complicated because I have to deal with not only the AMD changes, but also with the cystic changes in the neurosensorial retina as well. So a combination, a bad one possible, and also edema in the subretinal fluid.
Diferentemente do caso anterior, aqui a gente tem um descolamento do epitélio pigmentar seroso, porque a reflectividade interna, ela é hiporreflectiva, o espaço e homogêneo, o que diferencia do descolamento de epitélio pigmentar no caso anterior.
Yeah, so you see actually here, now you see the difference of the lining here and the elevation of the whole retina with the, you see the hyporeflective space below it and the subretinal fluid above the pigment epithelial detachment. So there is a difference between the two images, the images from before and the image now. Pode mostrar a imagem anterior de novo, Jéssica?
Posso? Apareceu?
Não, ainda, not yet.
Ele está com um delay.
It's getting a little delay. But, this is interesting. Vascularized serous retinal pigment epithelium detachment in the dome-shaped fashion. And this was the image from before. Okay, go back to the other image, please. Pode voltar na outra imagem. So it's interesting. You have to see the whole thing, and you can actually see what is happening there, and this has less changes in the sensorial retina and more changes are in the posterior part. So you gotta see as a pathological cut, as you see the whole thing. This is very elevated, hemorrhagic retinal pigment epithelium detachment.
Isso, também o caso de hemorragia, esse descolamento do epitélio, ele vai iniciar hiperreflectivo e vai ter uma atenuação, ficando hiporreflectivo, assim como o caso do seroso.
And you see the hyporeflective spaces at the sides of the hemorrhagic retinal pigment epithelium. So you got to see, because if it's the image like that, it's where the image doesn't arrive or reflect much. So you see the hyporeflective spaces. The blood under the RPE appears hyperreflective, actually attenuates the signal from deeper structures. So that's why you see the image not that bright.
Aqui caso, então, de elevações com drusas. As drusas de EPR, elas podem se coalescer e também fazer descolamento do epitélio drusenoide.
A drusen, and the drusen might get together and coalesce and cause this image that you see there.
Aqui também a gente consegue ver na seta uma disrupção dos fotorreceptores adjacente às drusas pelo sofrimento dos fotorreceptores na área.
And you actually can see distortions at that area around the easy zone and distortions of the photoreceptors. And the topography is there is the foveal central area. So that's where you have to take a very good look at. And actually, this shows you a little bit of the outcome of the patient.
Aqui caso de atrofia geográfica, onde a gente tem afinamento importante da retina, com a perda das camadas externas, aqui de zona elipsoide, toda perdida na região.
You have geographic atrophy, and the whole thing, the posterior retina there, is kind of lost and atrophic.
Aqui caso de cicatriz disciforme, onde a gente consegue ver uma área hiperreflectiva na parte externa da retina.
So you have this scar and geographic atrophy, and you see this hyperreflectivity at the posterior area, occupying all area there. It's actually looks like a scar.
E a anatomia normal das camadas da retina é toda perdida.
And so that influences all anatomy of the overall retina, because the scar takes all this area and distorts the rest of the retina.
Aqui caso que ajuda muito a saber quanto à cronicidade do edema, que é a tubulação na retina externa. A presença aqui de cisto grande antes da injeção de anti-VEGF, o cisto melhora após a injeção. Ao contrário dessa estrutura tubular, que quando presente, ela se mantém devido à cronicidade desse edema.
Yeah, with the chronicity of the edema, you may actually find tubular changes. These tubular changes get the case a little more difficult to be treated. And they might appear, and you actually can see these retinal tubulations in some chronic age-related macular degenerations as well. And as you see here, it's called outer retinal tubulations. You see especially in the more chronic cases. And as you see here, these malar cysts corresponds to an outer retinal tubulation, which is frequently present in patients with chronic and advanced age-related macular degeneration.
Aqui uma diferença entre o descolamento do EPR, que é essa linha hiperreflectiva com descolamento do EPR, e o descolamento da retina neurosensorial, associado a uma chorioretinopatia aguda central.
So it's very important that you take a very good look at all structures, and you see the sensorial retina very elevated there. It's the retinal detachment, and you see the RPE detached. It's like a dome-shaped. You see the lining of the RPE. It goes straight, and then it goes suddenly up and down, and then you see that you have the association of the two changes.
Outro caso de descolamento de retina tracional diabético, onde a hialoide posterior hiperreflectiva está tracionando e deformando a retina, fazendo descolamento neurosensorial.
As you see here, these tractional retinal detachments from diabetic retinopathy, you see the very thick posterior hyaloid distorting the retinal architecture with traction, and you see fluid under the retina.
Caso de edema retiniano devido à oclusão de ramo de veia, onde a parte não acometida está intacta e com presença de grandes cistos intraretinianos no edema na plexiform externa.
And so with the next image, you see here the occlusion, vascular occlusion on the left. It's a branch, retinal vein occlusion. And you see the overall retina thickened on the left. And the plexiform layer has cysts over there. And these cysts at the retinal plexiform layer, they might appear as well in the other parts of the sensorial retina. So the OCT gives you an advantage that you can actually make the good surveillance and before and after injections and seeing whether the retina is getting back to normal after the treatment.
O edema extracelular, ele gera essa imagem cística intraretiniana. Ao contrário,
Extracellular edema generates this cystic image.
Ao contrário, no caso de oclusão de artéria, a gente tem o edema intracelular. E aí a hiperreflectividade na camada interna da retina é devido a esse edema intracelular.
So that's the opposite from the central retinal artery occlusion, where you have the edema in the intracellular space. So the hyperreflectivity is not this. You have the image? Você tem a imagem?
Já deve estar chegando aí.
The image is coming.
É a oclusão do ramo de artéria.
So next one is branch retinal artery occlusion. You may notice the difference.
Pareceu?
You see? Yeah. Pareceu, yes. And branch retinal, it's very interesting because you see the hyperreflective in the whole structure over there, and the increased thickness and the hyperreflectivity of the inner retinal layers in the inferior foveolar area, denoting the presence of intracellular edema. So because you see the edema in the whole retina, you see the whitish image in the whole structure, and not like only hyperreflectivity where cysts are here and there. And so the branch retinal artery occlusion has a different appearance. And you know actually also that the miliary cells, they go the retina all thickness. And so the whole thing gets edema.
E por último, essa alteração que usa o OCT como um dos critérios diagnósticos, que é a PAM, maculopatia média paracentral aguda.
Yeah, paracentral acute middle maculopathy. And
a gente tem associado uma área de hipopigmentação, palidez na retina paracentral à fóvea, associado a uma área de hiperreflectividade nas camadas nuclear interna da retina.
So it's very interesting to look at the OCT and have a very good and sharp image, because you see the hyperreflectivity there in the inner areas of the neurosensorial retina, and you see on the left, you can actually see the image, that hyperpigmentation, and on the left, and compare with the hyperreflectivity of the inner nuclear layer, and where the whitening seen in the same area where you see on the left the whitening on the retina, the picture, and you compare to the right. And if you don't have a very accurate OCT, you might not see where these changes are. And that gives you the individualized layers of hyperreflectivity.
Thank you.
Very good, Jessica. Very good cases and interesting cases. And we can never forget to see what the OCT shows us. There are 4 more cases. I want to share with you more cases separately. But we got to see what the tool gives us, and of course the old OCTs from the past, they still help, but they don't help much like the, the ones that don't, the image that doesn't get too sharp. Then we have better OCTs, and we have to take advantage of these ones. Thank you, Jessica. Your lecture
you.
was awesome.
Thank you, Dr. Jessica. I think excellent presentation.
Thank you, doctor.
We have Dr. Jaydeep, Dr. Nano, who's a consultant and director in Jakarta Center in Indonesia. And we have Dr. Sheila John from Shankar Netralaya, Madras. That's my alma mater. Hi, Nano. Nano was trained in Aditya Jyot about a decade back, and now he's a consultant and director in Jakarta, Indonesia.
Hi, Nano. How are you doing?
Hi, Nano.
Hi. How are you?
Yeah, fine.
All good.
That was my last trip to this year in February 7th, 8th to Indonesia, to Jakarta. I inaugurated their Jakarta Center trauma.
I don't know Jakarta yet, but I hope I'll visit soon.
Yes. So any comments,
Hopefully.
Nano and Dr. Jaydeep?
So
It's
very
a
nice presentation.
yes.
So I think Dr. Jessica covered all the macular diseases where we use the OCT so often quite well, and described all the changes that we see in the most common macular conditions. So excellent presentation.
Thank you.
Very excellent cases. So it seems we have to see OCT more detailed so we can conclude the diagnosis of a patient. Very nice cases.
Yeah, I always tell the residents and fellows that we have the angiogram that we're going to hear now, and OCT, we got to not only do the right screening and examinations from the patient, but we have to take these things to the OR. We have to take to the laser room the angel to see where the microaneurysms are, where the edema is most, and so we can plan to do the right grid laser. We can do the focal laser, and these things people are not doing anymore, because of the era of the injections. So people forget to do. No, I have to do these microaneurysms burning with the laser here and there. They don't have that patience anymore, and we gotta have the not the angel in hand to do the thing, and including the OR, not only the OCT. So we are gonna be talking now about the
I agree with
angiogram,
Dr.
how
Hudson.
important.
There's one important thing which we should also do is in the OCT is that we should actually know how to do the OCT yourself. I mean, I don't know whether the residents are doing the OCT or the technicians, but then it's very important that you learn the machine and the different parameters, different scans that the machine can do. And when you actually, before you decide, you should go to the machine and see all the scans rather than just seeing the printout or the report which is generated by the technician.
I
And
agree
also,
completely.
you should know how to report the OCT, the terminologies used yourself, so that you can generate the report for the patient, and you should document your findings so that next time when you see your patient, you know like what you had noted on the OCT.
Yes, what I like to do, JD, I take the OCT from somebody else, and if the scans are not in the appropriate position, I ask them to repeat, and sometimes you don't have the actual measurements, and the technicians, they have to learn I've taken some OCTs where the patient was looking to the left and the OCT was made and he did not pay attention and I have to have it repeated. So it's very important that you have the accurate image, the right measurements. And during the OCT examination, you can actually change the scans. So it's important that the technician has good knowledge, not medical knowledge, but at least where the structures are. And when we order the OCTs here, I write, no, I want the scan to go past straight into this scar here, because I want to see, compare the scar with the overall retina, whether it's comparable or not, you know?
Yeah, always, it's very important to either talk to the technician or to write down where you want the scan to go through exactly so that they know where to focus.
Yeah.
And sometimes you need to repeat the scans, as you said, because you really want the scan to pass to the exact location that you want. And any diagnosis, I don't think is based on seeing a single OCT scan. So you need to go and see all the scans, all the images passing through all the sections, and then you get a better idea.
Yeah, that's it. That's it. And it's very important also for macular hole, for example. And, the old classifications from macular hole, you saw these, 1, 2, 1A, 1B, 4, this and that. But now you have the most modern OCT classifications where the vitreomacular tractions over there, vitreomacular traction doesn't count. So you have the small, medium, and large macular holes. So with the OCT and the appropriate measurements, you can predict whether you have a good or bad closing possibility. If you have a very large macular hole, you've got to plan more things to do. And then if you compare to the old gas classification, which is still used, you have the tractions, 1, 1A, 1B, and then, but now the newest classifications from OCT, where we use OCT to actually make the classification for the macular hole, we only use small, medium, and large macular holes. So it's good to have a good OCT and make the measurements. Otherwise, after the surgery, you cannot compare. It's important that you compare. And some OCTs still give you a possibility of seeing 3D, which I don't use very much, the 3D. I prefer the 2D, but some of them make movies. Our OCT that we have here, the Cyrus, we record all the OCT passing through the macular area. So it's a good tool as well, so that we know what we are doing and what we have, the tools we have, and we use the best way.
Right.
Anybody else wants to say something? Now, anybody wants to comment? Dr. Sheila? Dr. Joshua?
No, I have nothing to add. I think he's spoken very well.
This was very well explained.
Yes.
Hello, Carlos. Carlos Câmara. Both Carlos from our fellowship just came. Carlos Alberto and Carlos Câmara. How are you doing? Do you have any comments, Carlos?
So 2 days back, we had a symposium on cataract and AMD, and then they were recommending better to do a OCT in all the patients to undergo cataract so that you don't miss any changes in the macula, so that they also can assess the macular function, the macular anatomy at least.
You remember, I have to tell you something. This is probably the opportunity. Like 25, 30 years ago, I used to scan before the OCT was available with the RTA. How many of you heard of retinal thickness analyzer? This was interesting. We had these cuts over you know, the macular surface there, and it was so good to see the macular holes. And unfortunately, or fortunately, because the OCT came, and but before, in between the OCT and the RTE, and just the beginning, we had this scanning laser ophthalmoscope as well, which did very good images. But I remember the RTE, the retinal thickness analyzer, and we still have one RTE for sale, you know, from another service. A friend of us here is trying to sell this. This is a tool that still may be used in some cases. So that's something from the past that gave accurate images from the hole. You see all cuts and whether the hole was closed or not. So still, for those who don't use the OCT, you might or you should refer it to somebody else to have the OCT done, because it's so important. But for diagnostic reasons, it's not forbidden for you to do surgery without an OCT, but you still have the Watzke, very simple test, Watzke-Allen test, the sleep lamp. But if you have the OCT, the things go much better. I actually cancel some surgeries where I don't have the OCT in hands, but I only, most of my cases I set up for surgery after they have the OCT ready, so that I have to see the exam beforehand, and so I plan the surgery. But if I have to cancel for any reason, I don't have OCT, referred to do macular work from somewhere else, I prefer not to go ahead and not to do the surgery.
Aishwarya, do you have any other presentation, or you have anything to say?
No, so that was a very good presentation. Actually, I think Dr. Jessica covered everything basics to advanced, and she took every pathology into consideration. That was very good for me, sir. I just have one doubt, sir.
Yes.
Hello? Yeah,
Mhm.
just one
Hey,
doubt.
yes.
Sir, yeah, I was wondering, sir, is it compulsory to do an OCT scan as a precautionary measure for every patient undergoing cataract surgery? I mean, I've attended some CMEs where there are a lot of mixed opinions about this. So, sir, I just wanted to like cross check once. What is your view about it, sir?
There are some papers, they perform OCTs before the cataract surgeries, and I've heard a lot those years about that. But for me, the main indications is there, if you actually saw in the retinal mapping, you see the retina in the, if it's okay, I wouldn't go ahead and do OCT. I would probably better, in case of diabetic retinopathy, for example, I would treat the patient beforehand. But if you have this cataract, which is not so important, and the media is not so hazy, I think it's not excessive to go ahead and do an OCT. And
so if the media is clear and clinically the retina appears normal, then if we give the fitness for cataract surgery saying, yeah, okay, retinal evaluation is totally normal, but sometimes if there is even a minimal, like a very, very early stage AMD or something, so which we may miss clinically, so wouldn't that create problems for the patient post cataract surgery? Because post-operative pseudophakic CME will be very high in such a patient, right?
Yeah, I understand, but I don't usually do, because if you have pre-proliferative diabetic retinopathy, which you see the changes there, you see irmas, you see, pre-neovascular changes, and you actually see it's pre-proliferative, and then the patient has also edema. You know that after cataract surgery, he's going to develop this worsening of the macular edema. And so in those
Right.
cases, I would perform, especially if I have not very much hazy media, so I would do that for sure. But in very mild cases, even though you know that the diabetic retinopathy patient not treated, if he undergoes cataract surgery, he's going to develop some worsening of the retina. But if he's under control, if his glucose is okay, and the endocrinologists say he's fine, and you have very mild changes, and he's already had laser in the nasal parts of the retina, so you could actually prevent the VEGF from raising to high levels. And so I wouldn't do the OCT in these very mild cases. I wouldn't do that, but only if it's necessary. You have to operate, you have the membranes, the patient has to go to the surgery because the vision is worsening, and we gotta follow the retina better. And so then the cataract is in between there, the situations, then I would do surgery for the cataract. And also the OCT. But not in mild cases. I wouldn't do OCT in mild cases. Would you, Natarajan?
Jaydeep, what is our protocol? Jaydeep?
Sir, we are not following routine OCT for pre-op cataract before cataract surgery, because I don't think most of the institutes are following it, because there is no significant substantial data that we have that we miss clinically after clinical examination. If the media is reasonably clear, I don't think we miss anything which can exacerbate post cataract surgery in a short period of time, say about a month. So rarely we get such patients. If we suspect there is some pre-existing retinal pathology, or in case of hazy media and we have some doubt that the cataract, the vision is not proportional to the cataract that is there, which means the vision is probably much lesser than the degree of cataract, then we can go ahead and do a OCT for such cases, but not for routine cataract surgeries, because if we can see the macula clinically well, then reasonably we can say that there is no pathology. So
Okay,
in
sir.
Aditya anyways, we are not following. In Shankar Netralaya also, we were not following the routine OCT before cataract surgery.
Okay, I agree. And some insurance plans, they don't actually pay. That's the problem, here in Brazil, we need to have strict indications. Otherwise, the insurance plans could give you a problem on that. And maybe if you order one OCT, for example, you need some space in between another OCT so that they could approve as well. That is another problem, that depends on the local policy from each country, I guess.
Yeah, agree. And in India, there is no insurance most of the patients, so it's a cost burden definitely which gets added to the pre-op investigations which the patients already has to do.
Yeah, in the chat box, so many structural problems are found during a routine screening. Lots of cysts, BFT, mild DMO can be diagnosed by ophthalmoscopy. So I would say yes. That's what you mentioned. And I should do any other presentation we have today?
Dr. Pooja is here, sir. She's prepared with an FFA presentation.
I know. Today it is?
That was the plan, but yes, sir. That's the plan.
It's already 4:30.
Yes, sir. So shall we push it?
We can have it next week.
Pooja? Yeah, that's what I'm saying. Pooja?
Yes, sir. Yes, sir. Please, sir.
No, we can have it next week.
Yeah, no problem, sir.
Yeah, because Dr. Jessica wanted to do today, I believe. That's what I should do. We can do it.
I think we could have next week because, there's so
SFA
much
is a big
to discuss.
Yeah,
and next week we're going to have OCTA and I think FA because, we need time. It's so good to talk.
I think
and then
we can have one topic during one meeting because FFA itself is a very big topic and also OCT angio. So maybe we can have it one at a time.
So OCT angio we can do. No, OCT angio we can do a week later.
Okay, sir. Sure.
Yes, sir.
So that we
Agree.
have, now we have covered OCT, then we have PA, which is the basic investigation. And
Yes,
then
sir.
we can then do a OCT and have a comparison that time.
Yes, sir.
Yes,
Definitely.
yes,
Sure.
sir. Makes sense.
Okay.
Okay, sir. No problem. No problem, sir. No problem. I'll
Right.
present the next. Okay, sir.
That's
Yeah.
great. Yeah.
So any
Anybody
other
wants
questions from
to comment more?
Pooja? Any questions?
No, sir.
Rodrigo Morato from Brazil. Do you want to give your ideas? And Carlos, both Carlos Camera
No,
and
doctor, I think it's very explained.
Okay. And I think it was well explained. And do you think the examples were enough? We could probably add next week other examples. Did you like it, Rodrigo? I will share with you later in the WhatsApp group a lecture from Dr. Wai-Chin Lam, and he was showing the OCTs and the examples. It's very interesting. I will share with you later on as well. And Dr. Nano, you are in the OR?
No. I'm at my home.
Ah, okay. So because your picture there was you were close. I thought.
He's actually
You were with
it
the
is around
scrubs.
6 o'clock in the evening.
Yes, it's
Okay.
already 6 o'clock in the evening.
Yeah, it's
So you
4:30
are
in
done.
India. 6
You are done for the
o'clock
day.
in Asia.
During
Okay.
COVID, our work hour is reduced to 4 o'clock in the afternoon. So I'm already at home right now.
Yeah. We reduced our schedule, but we're still going to surgeries up late. You know, the foundation will have too many patients over there, and I guess IDTR Giant Hospital is the same as well. And things are getting back to normal, but everybody is still concerned because now those days we have relatives that actually got COVID, and we know that the thing is very serious. And we hope that things are going to be settling down pretty soon.
Yes, but in Indonesia, it's very bad condition right now. It's about 1,000
And
new cases a day in Indonesia. So
Oh, 1,000.
yes, 1,000 cases a day.
Yeah.
Hudson, so I actually wanted to do a review article on vitreomacular traction. So maybe it's pending for 2 years with me. Maybe Jaideep, if Nano is interested from Jakarta, and then Aishwarya from outside. We should make something like a Excel sheet and then share it and start collecting patients.
Yeah, very interesting subject,
Sure.
especially when we think of vitreomacular traction, and with time, the OCTs that we use now, the new classifications, and the
Classification
outcomes.
just, changing.
This is a very good subject. And then I have that video, that video was pretty sharp, the images where we shown the triple peel, and we removed the vitreomacular traction, and also we went after the epiretinal membrane and then internal limiting membrane, and we could see without staining. The last we stained was the internal limiting membrane, but before the internal limiting membrane, we didn't stain anything. The only thing stained was with brilliant blue, the internal limiting membrane. So with the lenses and the zooming in and out and the macular lenses, we could see the structures, the vitreous, the adhesions, the epiretinal membrane, and that's good when we have also a good microscope with the appropriate lenses and good subjects. Good ideas. Good idea for a speech, Natarajan. Vitreomacular traction.
Yes, and Hudson, there's a academic company called Omnicures, OMNICURES. So they actually get CME credits for the medical council in India. So I have spoken to them about our PG program. So Aishwarya is coordinating. So from next week, probably whoever attends and they can fill up that form in India, they will get a CME credit.
Yeah, that's perfect. And I'm gonna talk to the Brazilian Vitreoretinal Society, and see make the link as well, so we
Yeah.
could probably have the same CME. This is very interesting. You see, this is very important, and so we get to learn, and you see the results. So very good idea. Congratulations for that. Congratulations, Aishwarya.
Hello, can you hear me?
Yeah. Mm-hmm.
Yeah.
Yes, thank you.
Congratulations for the CME coordinating thing, and this is
That was Natarajan sir's plan and idea, brilliant idea actually, that we'll coordinate with this company and get the CM.
wow. This is how do you call the
Yeah, actually,
Omnit Kurus? What the name is?
Oh, I'll type it.
I'll send you the link, sir. You can have a look at the website.
Okay.
actually,
I've typed it in the
are
chat box.
required for updating your medical council registration. For your medical council registration, you need to collect these CME credit points. So whenever you are renewing, you have to submit them.
So you have to find out. I don't know how the other people can access from the rest of the world. Aishwarya, we India, we can
Yes,
fill up
sir.
our number. They're asking for a number, medical registration number.
Correct.
For foreigner, I don't know how do they see the presentation.
So I think they can see it, but I don't think they'll get the credits, sir.
Can they see it? How they can register? Maybe you should find out.
No, I'll speak with Soumya and I'll let you know, sir.
Okay, you can say hello to Dr. Nano, who's our alumni and he's director in Indonesia. Nano and Jaydeep were colleagues.
So thank you very much for everything, Natarajan. This shirt is awesome. It's 10 over 10.
Brazil, yeah. Obrigado.
Yeah, I'll make a picture here because this is so beautiful to see the Brazilian. Our soccer team is famous, and we gotta unite people with these things, sport things. And unfortunately, I think the Olympic Games won't happen next year. But I was an athlete in the past. I was a wrestler, and I took part in Pan American Championships as well. So I value
Wow, that's great.
my flag as you value yours. And when we got this year our Independence Days, we got so happy about that, and this is something to be followed.
Yeah.
Thank you very much for everything, and hope to see you next week. And
yes, and I also said
Thank
okay
you.
for
Dr. Nano, it was such a pleasure to have you. And
Yes, thank you.
everybody
It's
else.
very wonderful meetings.
Thank you. And Jaydeep, thank you very much for
Thank you, Dr. Hudson.
everything.
Nano, your
Great learning
postgraduate
experience.
fellows can join here. I saw Joshua already here.
Yes. I will ask
So your fellows
Sandy and Joshua to join it. Sandy and Joshua
Hi,
will join
Joshua.
next week. Yes.
Oh yeah, hi Joshua. How are you? You're in the hospital, Joshua?
Yeah.
Hello, sir.
Okay.
Okay. Thank you all. See you next week. And
Thank you. Thank you very much, sir.
Thank you.
Thank you. See you. See you next week.
Hudson.
Thank you,
Now
thank
some
you,
six.
everyone.
Okay.
Have a great day.
Yes.
No, a great night for you. A great day still
Yes.
starting
Yes,
for us.
nice.
Okay.
Stay healthy for us.
Thank you, sir, for having us.
Bye. Bye, Nano.
Bye.
Bye,
Bye. Bye,
Joshua.
JD.
Bye, Nano.
Thank you,
Nice
sir.
seeing you
Bye,
again.
Joshua. Bye, Joshua.
Bye.
Tchau, Jéssica, Carlos.
Bye, everyone. Thank you.
Thank you, sir.